some folks from the California side of Kaiser. It's sort of interesting because Kaiser in and of itself doesn't really view their DC practice as being fully Kaiser-esque. That because they don't have most of their own staff here, because they don't have most of their own hospitals, they operate more like a traditional PPO in this area than they are in California. Did you get that sense from the folks that you talked to, or?
No, actually, the sense I get is that, yes, Kaiser here isn't like California, but mainly because of its start. You know, Kaiser really started from some other groups, and which had issues, you know, like the old, what's it called, Group Health Association, or
Health Associates.
Yeah, group health. You know, had really very challenging labor issues with physicians, and you know, so I think part of it is that you know, they started with a weaker group than you have in California. But I remember when I read about 3 years ago that the medical group here had actually become merged into the Northern California group, and the head of the Northern California group was running it. This was basically Kaiser saying, we want to make this real Kaiser. And I think Kaiser in some other areas it's been successful, like say the Denver area in Colorado. They don't own hospitals there. And even in California, if you go from city to city, you'll find that in you know, some of them Kaiser is not as large as a percentage of the population as others, and they use more you know, physicians in the community. But it's different than a PPO because, you know, so if you need a very specialized, say, neurosurgeon as a Kaiser member, you know, Kaiser will have a contract with a certain, you know, they will send you to that particular neurosurgeon. It's not like just, you know, having you go on your own. And the trend in Kaiser has always been to insource more services as it becomes economical and practical to do it. So I would say that, you know, Kaiser here, you know, in 10 years could look a lot more like Kaiser in California, except for not owning its own hospitals.
I would add, Kaiser made a significant capital investment into new facilities all over the DC region, in the district as well as in the greater Washington area. And that shows their commitment to growing their presence and their business here. And if you ask me in 3 years what their market share is, I would guess that it's going to grow substantially from where they are today. They offer a point of service, several point of service options in addition to the traditional HMO.
Wonderful story of the success of the health exchange. Obviously, you're trying to deal with a shrinking number of uninsured. What is that? What is that number of percentage change?
So is it
3.5%?
Yes, and significant portion of the uninsured would qualify for Medicaid coverage, but we have no wrongdoers, so we try to find everyone.
So essentially what you're saying is the number of insured that's through the exchange on the individual market, you're pretty much at that's what that is going to be, that's that capacity.
No, I wish I could say that. We haven't found everyone yet who would qualify for either APTC or full pay. So one of the challenges we have is most of the national population surveys, health insurance status surveys, don't hone in enough on just DC. They cover the greater Washington area. And so it's hard to gauge how many people are still left without coverage because the surveys and the margin of error is just not precise enough for us. But we think probably 18,000 or so with significant Medicaid. So at least a third probably private coverage Leighton, and you can correct me if I'm not remembering
I think that's possible, and, you know, obviously the other potential depends on, I mean, we have a very strong employer-sponsored health insurance market in DC.
Right.
And so some of it may also happen, depends on, does that market change? I mean, historically nationwide, employer-sponsored insurance coverage has been dropping continuously for a number of years. In DC, it's a little different because the federal government is so strong here, and because, as Paul said, a lot of the private businesses that are here are relatively well-to-do, want to compete with, but that could change over time. And so to the extent that we lose employer-sponsored coverage, then conceivably more people will be turning to the exchange. So, you know, how that changes. But for now, I mean, we're fortunate that there's not that huge demand that you see in other places, like in California, in comparison. And it means that the health exchange is not as large, relatively speaking, here as in some other places. But when all is said and done, on balance, that's a better place to be in.
You know, I think you raise a great point on job-based coverage. We have estimates that RAND did for us a couple of years ago through the contract they have with the federal government that actually showed that our job-based coverage would increase in DC and not shrink like the prediction is in other states. It's too early to see any trends. We do have on the shop side many small businesses who are offering coverage for the first time. So, and many in the sectors that traditionally have very low offer rates, like the restaurant business, many restaurants offering coverage for the first time. And these are small businesses. They don't have to. There's no requirement for them to offer. So it is interesting to see. In a couple of years, we'll have a better sense of what's happened. But on the individual side, there's still some people for us to get. Okay, I don't know where you want to start.
Just for anybody, are there?
And let me just add, because we're going a little over time, in fact, a fair amount over time. Maybe two last questions, but go ahead, Aaron.
I was just going to ask, to what extent does the DC state government or other local governments have enough market power to have?
I couldn't hear the end of the question.
Like, to what extent do the local governments have enough market power to have any kind of impact? I was just thinking about DC compared to, you mentioned California, where there's a lot of push from the state level.
Well, I would say in general, local governments don't play a role in health insurance and a lot of healthcare. They, you know, for the most, you know, the most important government is the state government, and so you know that's why DC, because it's somewhat of a state, plays this role. So in a sense, so if you go over to Arlington County, do they play a role in health insurance? No, and that's normal.
I guess, yeah, I was wondering when you're talking about DC being behind the curve in terms of catching up with value-based payment and those kind of innovations. Do you see other states, like I was thinking like maybe New York State or the state of California, being more involved in, like, through their employees, through state employees?
I see what you mean. Yes, I think for the most part, you know, when I said DC is behind the curve on that, it's not because of the government. That's just the nature of the healthcare market here, the health insurance market, that there's much less sensitivity to high premiums here, and that's why employers aren't pushing the insurers to do it. Insurers aren't doing it because their customers don't care that much. You know, there certainly are examples in California, probably the CalPERS activities have pushed it forward, but I think the dominant force that explains how California is today has been the successful, large Kaiser Permanente presence. And that's what really drives California to be different.
DC, just to add to that, DC recently was awarded a planning grant under the state innovation grants, and there's a whole collaboration led by Department of Health and healthcare finance and other folks to look at value-based purchasing in the Medicaid model. And there are lots of people at the table for that initiative. Health plans are at the table, and we are at the table. So there is a renewed energy and interest in looking at payment reform, delivery system reform, looking at what Care First has done, looking at Maryland's initiatives. So there is, I would say, a very new, renewed interest in becoming more active in payment reform and delivery system reform.
I wonder if you could comment briefly on the changes you see in the premiums for the various plans and what accounts for those.
Full disclosure, we advocate for all of our customers. So every year we have consulting actuaries who actually review rate filings for us and provide information and feedback to the insurance department. The insurance department approves final rates, but we weigh in. And so we always advocate for the lowest possible premium for our customers based on actuarial analysis. This year, the proposed rates that were filed actually did not have the same significant increases that you saw in Maryland from the same carriers. And I truly believe it's because we have the full transparency on rates and coverage, that there is a competition element. Carriers don't want to outprice themselves out of being competitive. The ultimate rates that were approved were much lower than filed. Now, any rate increase, $1, could mean a difference for some people staying insured or being uninsured. So I don't mean to say that even $1 is not important to some people. It is. But we saw much lower approved rate increases than other states. John Gable recently did a study looking at, I think, 5 or 10 states, and I think his slides are up on the Alliance for Health Reform website, and DC was in the category of the lowest price increases. So we're very happy about that. We don't want to see any price increase, and ultimately that's where we'd like to be, but we're pretty happy that what we ultimately advocated for and what was approved was much lower than what was proposed.
Excuse me, Mila, when the administration started allowing various grandfathering steps for people in in individual plans, was that allowed to go through in DC or not?
No.
And that's a key reason. I think that the states that have had the biggest increase are the ones which allowed all this grandfathering, which meant that their risk pools for the exchange were, less healthy, fairly sick people, and that 2016 was the first time that the insurers had had time to really study the experience, realize how bad their experience was, and then raise their rates. So in the states that did not get involved in that, their increases in 2016 were quite modest.
Yeah, you're absolutely right. Plus all the uncertainties, not only the population you'll get, but also the uncertainties with risk adjustment and reinsurance and the risk corridors. There were just lots of uncertainty the first year, I would say, in pricing, which also probably contributed to more conservative rates than really warranted. Insurers that aggressively priced had a mixed experience. Some of them had to have double-digit rate increases because they just didn't price well, and others did really well. They gained market share as a result. I think one of the most competitive markets to look at in terms of pricing is Kentucky. They got a bunch of new carriers in that they didn't have before, and they priced pretty well for that market.
So I think we've used our time and heard wonderful talks. So I thank both Paul and Mila for providing all sorts of information. And I'm sure if people have more questions they want to ask, we can pass along email addresses, and people would be happy to
context, I hope.